In the last video, we left off talking about the relation between pressure and volume. And we actually know that there's an inverse relation between pressure and volume because of Robert Boyle, this guy. And he's responsible for what is called Boyle's law, which simply states that there is that inverse relation between pressure and volume. So as one goes up, the other will go down, and vice versa. So how does that apply to breathing? Well, when you're at rest, we know that atmospheric air is 760 millimeters of mercury. And when you're at rest within terms of breathing, that would mean you're not actively breathing in and you're not actively breathing out. So inside your lungs, the atmospheric pressure would also be 760 millimeters of mercury. And the interpleural pressure is slightly lower. And this is to facilitate your lungs actually not collapsing, that we have that difference in pressure. So then when we go to take a breath in, inspiration, it's an active process. The diaphragm is going to contract and go down. The external intercostals are going to contract and pull your rib cage up. So what I'm doing is I'm effectively increasing the volume in my chest cavity. If I increase the volume in my chest cavity, inside my chest cavity, i.e. my lungs, pressure is going to go down. So what was 760 millimeters of mercury when I was at rest, neither breathing in nor breathing out, is now below 760 millimeters of mercury. And air is going to want to move down a concentration gradient. So it's going to go from the high pressure of 760 millimeters of mercury in the atmospheric air, and it's going to want to move into my lungs, down that pressure gradient. Kind of how a vacuum works to some degree. So that's moving air in. Well, now the opposite, whenever I am trying to exhale, right? In that case, I have passive relaxation of my diaphragm and my external intercostals, so I'm going to decrease the volume in my lungs. Well, now the pressure in my lungs is going to be higher than atmospheric pressure of 760 millimeters of mercury. Maybe it's 764 millimeters of mercury now inside my lungs. That's going to facilitate air moving out of my lungs and back into the atmospheric air, always moving down its concentration gradient. So practice this a few times. Can you explain this to someone who doesn't know anything about breathing in a way that they could understand that inverse relation of pressure and volume, and that when the change in volume of the lungs occurs, that's causing a change in pressure, which is going to dictate where the air is going to go, either into the lungs or out of the lungs. So let's review again what happens with the mechanics of breathing, because this is an important concept. Remember, we're trying to move bulk amounts of air due to pressure differences, and we're creating the pressure differences by changing the volume inside the lungs. So during inspiration, as the diaphragm presses downwards and the ribs lift up and outward, the volume of the lungs would be increased. This would cause intrapulmonary pressure to be lowered and air will move in like a vacuum. During expiration, the diaphragm will relax as well as the rib cage, which will pull downward, and the diaphragm is going to move upward. This is going to decrease the volume in the lungs. This will increase intrapulmonary pressure and air will move out of the lungs. Remember, we're always going to move from an area of high pressure to an area of low pressure. The primary muscles of inspiration are, as we mentioned, the diaphragm, but more specifically the upper and more lateral external intercostals, as well as the peristernal portion of the internal intercostal muscles. Both the external intercostal muscles and the peristernal portion of the internal intercostal muscles all work to elevate the rib cage. Do respiratory muscles fatigue during exercise? That's a really good question. And in the past, as an exercise scientist, I would have told you no, respiratory muscles don't fatigue during exercise. But now we know that that's not true, and that respiratory muscles can fatigue during exercise, but it's very specific types of exercise that they will fatigue. So not only does the exercise need to be very high intensity exercise above 80% of someone's VO2 max, but it also needs to be very long exercise. We're talking about an hour and a half, 2 hours plus of this very high intensity aerobic exercise that you'll actually see some fatiguing of those respiratory muscles. So on this slide, you see a picture of someone wearing one of those altitude or Everest masks. And when these first came out, I'll tell you, I totally hated them. They really annoyed me because they advertised them as mimicking what happens whenever you go to high altitude, which is not what these masks do, right? When you go to high altitude, barometric pressure is changing, which is facilitating some changes with your red blood cell count, specifically at the level of the kidneys. That does not happen when you put this mask on. What you're doing when you put this mask on is you're effectively giving yourself asthma, right? Or exercise-induced asthma, or you're like breathing through a straw. So you're inhibiting some of the airflow as you're breathing by using this mask. What that does though, is it actually helps facilitate training your respiratory muscles. So do these masks work to enhance exercise performance? Yes, just not in the way that they've been advertised to enhance exercise performance. So what's really cool is some of the European countries have started implementing respiratory training with their athletes. And what we saw is all of a sudden these countries like Switzerland and Norway and Denmark, they just started crushing everybody in the endurance style events in the Olympics. And everyone was like, why are these countries so good all of a sudden at these? Not that they weren't good before, they certainly were good countries in these specific athletic events. But their sports scientists started using respiratory training before other groups did. And that really translated to high performance on the most elite level. The most effective way, from what I've read thus far, to be able to use this type of training is to undergo your normal training that you would do. And that's not wearing a mask or doing anything, right? The idea there is you want to be able to exercise at very high intensities. You won't be able to effectively do that if you're wearing one of these masks or using some other device. The most effective way I've seen this used are devices that someone uses after their training. So let's say you go out and you run for 2.5 hours, you went out for a really long run. Then you would come home and use some sort of respiratory machine to fatigue your respiratory muscles. Because likely you didn't fatigue your muscles then, but you want to take them to fatigue as part of that training process where it's not going to be debilitating in the actual training activity. And that's where we've seen that transition to improving performance by increasing the oxidative capacity because you don't have any limiting factor of the respiratory muscles. Again, keep in mind, it's for specific types of activities that this would be effective. So you're talking about aerobic events where you're doing aerobic activity for a very prolonged period of time at a very high intensity. That's where we see these types of units actually work. So as we've already mentioned, that airflow is going to be dependent on a pressure gradient, right? So it's going to be the difference between the pressure in one area and the pressure in another area, and the air will want to move down the pressure gradient. But airflow is also going to be dependent on the resistance within the airway. Any decrease in airway resistance will increase the airflow to that area. Another way of saying that is less resistance, more flow. There are many chronic diseases that can change the resistance of flow through the airways. Good examples would be chronic obstructive pulmonary disease or COPD, as well as asthma and exercise-induced asthma. With asthma and exercise-induced asthma, we have a narrowing of the bronchioles, which would increase the resistance and reduce the flow. Generally, with these two conditions, it's going to be acute, so something that brings on an asthma attack, or if you have exercise-induced asthma, obviously that's happening because of exercise. With COPD, you actually have some remodeling and fibrosis of the airways, which narrows the pathway that the airway can move through. So you have some loss of that elasticity to allow for dilation, and instead you get smooth muscle contraction, thereby increasing the resistance and decreasing the airflow. Next, let's talk about pulmonary volumes and capacities. Pulmonary ventilation can be calculated two different ways. And just to specify, pulmonary ventilation is the amount of air that moves in and out of the lungs across a period of 1 minute. So one way to assess pulmonary volume would be to take the tidal volume and multiply that by the frequency of breathing. So the tidal volume is how much air moves in and out of the lungs in just one breath, and then the frequency of breathing is how often are you breathing in just 1 minute. Now another way to calculate pulmonary ventilation would be to use the alveolar volume and the dead space volume. And you would use these across 1 minute, and you would add them together to determine what is someone's pulmonary ventilation. We typically use the latter version, where we're taking the tidal volume times the frequency when we're trying to assess for pulmonary ventilation, which is a rate. The first pulmonary capacity is our vital capacity. And if you wanted to measure someone's vital capacity, you would have them take a maximal inhalation and then do a maximal exhalation. And you'd be measuring that total volume from when they were at the max inhalation to what they expelled after a maximal expiration. So if I was going to mechanically show you how to do this, I would take a very deep breath in, and I blow out all the possible air that I could. Now, there's some air that's left over that I can't blow out. That's part of why my lungs don't collapse. That volume of air is called the residual volume. And we always have some level of air left in our lungs so that our lungs don't collapse, and that is just kind of staying in somewhat of dead space within our lungs. One of our other capacities is our total lung capacity. And that's concerned with how much air is in the lungs after we take a maximal inhalation. So if I went, before I would breathe out, what's that volume of air? That would be my total lung capacity. How much can I actually stretch my lungs and fill them with air? Now, I just walked you through some of the more common lung volumes and capacities. But there are additional ones that we're going to use whenever we're assessing somebody's overall lung function. So what I want you to do, instead of me being monotonous and going through each one and demonstrating, is I want you to read through each lung volume or capacity, and I want you to practice what you would do if you were going to be the person who is having this measured. And there's a really good description as well as the abbreviation that we use for each of these measures. On the next slide, I want you to go to this slide that shows spirometric values, and it visually will show you what each volume looks like on that graph, and it also shows the corresponding correct volume. So as you walk through step by step for each of these volumes and capacities, look at that graph as you're reading the description from this table, and make sure that you understand how each volume would be calculated. Make sure you can match each of the terms from the previous table to this schematic. It'd be really helpful in your notes to go ahead and draw and label and write out the definition of what each of the volume or capacities are that you can see on this graph. If you have trouble reading this graph, let me know. As you go up on the graph, you're taking some sort of inspiration. As you go down on the graph, you're doing some sort of expiration. And you can see the tidal volume sort of in the middle of the graph, and that would just be your normal breathing that's occurring. So for example, my vital capacity, right, you see a very big inhalation followed by a very big exhalation on that graph. So this is how you can identify each of those different components. Spirometry is the most common of the pulmonary function tests. It measures lung function, and specifically the amount and/or the speed of air that can be inhaled and exhaled. Spirometry is really helpful anytime that you're assessing breathing patterns that identify conditions such as pulmonary fibrosis, cystic fibrosis, asthma, or even COPD. Spirometry is a really safe test in general. Sometimes people will feel a little bit of shortness of breath or dizziness right after they perform the test. But because it does require some level of exertion, if someone's had a recent heart attack or some other sort of heart condition, you wouldn't want them to perform this test because sometimes breathing issues can be a trigger. When you're doing spirometry tests, the two most common that you'll do is a forced expiratory volume test and a vital capacity or a forced vital capacity test. The forced vital capacity test is the largest amount of air that you can forcefully exhale after breathing in as deeply as you can. And a lower than normal FVC reading indicates some level of restricted breathing. The forced expiratory volume, this is how much air you can force from your lungs in just 1 second. The reading helps a doctor assess the severity of the breathing problem, and a lower FEV1 reading indicates more significant obstruction. So notice that we put a little subscript 1 after the FEV to denote how much is being expelled after just 1 second. As you can see in this video, we have values for a normal individual, so respiratory function being normal in that case, and then an individual who has COPD. You'll notice in our healthy normal individual that their vital capacity is 5 liters and their FEV1 is 4 liters. Whereas in our individual with COPD, their vital capacity is just 3 liters and their FEV1 is just 1 liter. Now, the other measure we haven't mentioned yet is actually just a ratio of these two other values, which is the FEV1 over the VC ratio. And what we're looking here to determine that someone has healthy normal respiratory function is we're looking for greater than or equal to 80% for healthy adults. You'll see that our individual with COPD has a ratio of just 33%, suggesting very severe obstruction of their airway.